Our next talk is entitled Risk Factors for Cerebral Hyperperfusion Syndrome Following Carotid Revascularization, presented by Ashley Zhu from the University of Southern California with senior author Greg McGee.
Good evening. Thank you for the opportunity to share our research with everyone tonight. Okay, these are our disclosures. Cerebral hyperperfusion syndrome is a rare but serious complication of carotid revascularization that can result in severe postoperative disability and high rates of postoperative mortality. In the setting of CHS, the incidence of intracerebral hemorrhage drastically increases, and rates of mortality after intracerebral hemorrhage can reach 42.5%. Immediate post-procedure hyperperfusion is common and often asymptomatic. CHS occurs when patients become symptomatic, but there are no formal diagnostic criteria. The syndrome is generally characterized by throbbing, ipsilateral diffuse headache, eye and facial pain, seizures, and focal neurological deficits related to cerebral edema or intracerebral hemorrhage. CHS is a well-described complication of carotid endarterectomy and transfemoral carotid artery stenting, with a reported incidence between 0 to 3% and up to 4.6% respectively. It's unclear if the risk of CHS is comparable between the two procedure types. A meta-analysis found that CEA was associated with the higher risk of CHS compared to CAS when using older studies published prior to 2012, but no difference was detected for studies published between 2012 and 2017. In recent years, transcarotid artery revascularization, or TCAR, has become widely adopted as an alternative to CEA, especially for high-risk surgical candidates. The incidence of CHS after TCAR has yet to be described, but deserves to be delineated given TCAR's increasing role in the management of carotid disease. Given the potentially severe complications of CHS, preventative measures such as tight postoperative blood pressure regulation, along with early identification and management, are imperative. For our study, our aims were to identify perioperative risk factors associated with CHS and to determine and compare the rates of CHS after CEA, TCAR, and TF-CAS. We conducted a retrospective analysis using the SVS VQI registry, and the postoperative outcome was, the primary outcome was postoperative development of CHS, which was defined as postoperative seizure and/or intracerebral hemorrhage. Since there are no formal standardized diagnostic criteria and symptoms of CHS can be nonspecific, we chose to use these two postoperative complications to capture the most clinically severe cases of CHS. All patients in the CEA and CAS databases were initially included and then further selected for CEA, TCAR, TF-CAS procedure type, age 18 and older, and procedure year between 2015 and 2021. Emergent cases were excluded. The patients were then further stratified based on procedure type. Ultimately, a total of 156,003 cases were included, and of these, 73% were CEA, 12% were TCAR, and 15% were TF-CAS. Patient demographics and characteristics are shown here in this table. Compared to the CEA group, the TCAR and TF-CAS groups had a higher percentage of males and patients with more complex medical histories, including prior coronary artery disease and revascularization, prior congestive heart failure, COPD, diabetes, and prior carotid procedure. The TCAR group had the oldest mean patient age, and the TF-CAS group had the highest percentage of urgent procedures and patients with a history of TIA or stroke. For postoperative outcomes, CEA had the longest total procedural time and a higher rate of postoperative cranial nerve injury compared to TCAR, while TF-CAS had the highest rate of in-hospital death and the lowest rate of postoperative MI. And these findings are consistent with results from prior published studies. In our study population, there were 333 cases of CHS. CHS occurred in 0.15% of CEA cases, 0.18% of TCAR cases, and 0.53% of TF-CAS cases. We performed a multivariable logistic regression analysis, and we found that TF-CAS was associated with a 3 times higher risk of CHS compared to CEA. We did not detect a statistically significant difference in risk between CEA and TCAR, but there was a trend towards a slightly higher risk with TCAR. Additionally, history of a TIA or stroke had a 2.5 times higher risk, and the need for urgent intervention had a 2.6 times higher risk of CHS. Degree of stenosis did not statistically correlate with an increased risk of CHS, except that treatment of a total occlusion was associated with a 4 times higher risk. There was a slight trend towards increased risk with higher rates of stenosis, but this was not statistically significant. Interestingly, other factors that were included in our multivariable regression analysis but were not associated with the increased risk of CHS are age, presence of contralateral carotid disease, and history of prior carotid procedure. In summary, we found that the risk factors associated with CHS are history of a TIA or stroke, urgent intervention, opening a total occlusion, and treatment with TF-CAS. TCAR was not associated with a statistically significant increased risk of CHS compared to CEA. The exact mechanism of CHS remains unclear, but is likely multifactorial. There have been many mechanisms that have been proposed, but the leading mechanisms are impairment of cerebral autoregulation, damage from free radicals, and breakdown of the baroreceptor reflex. A limitation of our study is the inability to capture all patients who developed CHS. Symptoms such as headache and eye and facial pain are nonspecific, so we had to narrow our definition of CHS to include only postoperative seizure and or intracerebral hemorrhage. By doing this, we captured only the most severe but clinically significant cases of CHS. Consequently, our results underestimate the true incidence of CHS. Another limitation is that we were unable to control for provider type and experience because this data was unavailable. Therefore, we were not able to assess if provider type contributed to the increased risk of CHS seen in the TF-CAS group. In conclusion, patients should have increased vigilance for CHS when performing TF-CAS, revascularizing patients with a history of TIA or stroke, and providing urgent intervention. Reopening a total occlusion should be avoided. Thank you, and I will take any questions at this time.
So really nice presentation. I think it is yet another example of why transfemoral stenting may just not be that great in operation, right? But I'd be curious for your thoughts on why there's a difference in hyperperfusion rates between transfemoral stenting and TCAR. Is it just patient selection? Is it unmeasured variables? I'm having trouble drawing why one of those would be increased risk of hyperperfusion. Stroke I get, but not hyperperfusion.
That's a great question. We are uncertain, but we do have a few hypotheses. So first of all, it could be, like you mentioned, selection bias, where the patients who are usually undergoing TF-CAS are, for some reason, contraindicated for CEA and TCAR. So there are some confounding variables that we may not have accounted for, such as like history of prior neck surgery or radiation. Additionally, we know that TF-CAS is associated with, they have a higher risk of, there are more microembolic hits, and because of this, this could break down the blood-brain barrier and then lead to increased cerebral perfusion and put patients at risk for hyperperfusion.
I'm glad Dr. Rajani asked the first question I had because I thought, well, maybe I just had too much champagne and I couldn't figure that out. But my second question has to do with blood pressure control. So one of the things that I think about is in these urgent situations where patients are coming in with a TIA and stroke. There used to be a question in the VQI, it's been a while since I've entered data, about blood pressure, highest blood pressure in the operating room or something along those lines. Are you able to look at blood pressure if there's any kind of regulation, if those patients had controlled blood pressure, if they had really high blood pressure in the OR, and if that may have affected it in some way?
Yeah. As far as I know, I don't think that information is available in the VQI database, but I can take another look and see if there's any trend there.
That was an excellent presentation. Thank you. There was a fairly comprehensive review on European Journal of Vascular Surgery about carotid disease, and their recommendation was to keep the postoperative revascularization blood pressure less than 140, and in diabetics less than 130. But was there any, did you guys look at the postoperative measurements of the blood pressures for these people, or?
Yeah,
And-
Unfortunately, since we were using the VKI database, we are unable to tell exactly what the blood pressure goals were post-operatively at these different institutions.
And the other thing was, I think, and I don't know how institutions vary, but provider information, I think a lot of the transfemoral carotid stenting is done by interventional cardiologists, interventional radiologists. Not to toot our own horn, and vascular surgeons are much better at managing our patients post-operatively, but I think a lot of times those specialties tend to not be as aggressive in managing the blood pressure. So I don't know if you guys can look into that.
Yeah, that is something we wish we could have looked into, but unfortunately that data was unavailable. So as I mentioned in limitations, it would have been interesting to see if provider type and experience did contribute to the increase we've seen in the TF-CAS group.
Okay, one more comment.
Really great talk. Andrew Kimball from Michigan State University. I found it fascinating that the contralateral side had no effect on CHS. And I don't know if it was possible or not in your database, but did you happen to look at intact circle Willis? Did that affect it at all? Was that something that you could look at?
That was not something we could look at with the database.
Okay, thanks.
However, for the presence of contralateral disease, something to note was that for the TCAR and the TF-CAS groups, there was about like 50% of the data missing in those. So something that we then took out in our sensitivity analysis and still found the same results.
Thank you.
Great.
Okay.
Thanks very much.
Thank you.